So this is a castle in Edinburgh, Scotland, from the park below it. There's actually, I think, used to be a loch that they drained and filled in, everything like that. It's a really cool park. So my friend from when I was in residency, they were postoperative fellow, but we met. We were both from Montana. I ended up going to visit him. He ended up in Scotland. I went over there a couple times. It's pretty neat. So this is Aneurysms Part 2. Once again, websites, me and Dr. Hughes, Twitter account, and then once again, just saying, I put that in there because, I understand general pathology pretty well, I believe, at the medical student level, and I think I'm a great one to teach that because my specialty is forensics, and I'm teaching the basics or anything like that, but I have a really strong interest in it, so I hope that makes it, I don't try and go off in the nitpicky details and stick to kind of what you guys need to know, I believe, so. Here are my disclaimers. Once again, read them, make sure that they do not apply to you, make sure that you should be watching this lecture, and if you shouldn't be, then just turn it off. There's disclaimer 3, same thing. Last one, like I said, if you're interested in my teaching method, it's under introduction. References. One question. So once again, pause, go through it, see if you can come up with the answer, and then we'll discuss it at the end. So we'll start with abdominal aortic aneurysms. So the major risk factors for abdominal aortic aneurysm, so it'd be an aneurysm, so it's usually a saccular outpouching in the abdominal aorta, so usually underneath infrarenal, so between the renal artery origins and the iliac arteries, but it can extend into the iliacs and potentially could extend above the renal too. Cigarette smoking is a major one. Hypertension, family history. So they're believed to be from at least partly due to atherosclerosis, because atherosclerosis thickens the intima, which can impair blood flow to the media. Also, if there's damage to the vasa vasorum and that. But the interesting thing is that in papers I found, diabetes mellitus obviously is strongly associated with atherosclerosis, but it's actually not associated with abdominal aortic aneurysms. There's also a prominent familial component, and the idea of the matrix metalloproteinases degrading the wall is very important too. So I think they're more than just an atherosclerotic lesion, because if they were, diabetes should be an independent risk factor as well too. So clinical aspects of abdominal aortic aneurysm. So a lot of them are asymptomatic. People don't know they have them. Mentioned before, pulsatile mass. It can cause abdominal or back pain because it's in the retroperitoneum. And then a compression of adjacent structures. So just think about it. It can compress the renal artery, the ureter, the sciatic nerve, and those can cause different things. Kidney failure, potentially, hydronephrosis, pain, everything like that. So, and then signs of it would be a pulsatile mass that can be palpated and then confirmed with ultrasound, CT, MRI. It's kind of amazing. When I was in medical school, there were hardly any ultrasounds done, but now it seems, at least wasn't a bedside procedure for the most part, but now it seems like it's really, really, really common, which is pretty cool. So to the right of it, that's a small incidental saccular aortic aneurysm. The yellow shows, you can see it's saccular is bulging out from the side. So to the left is an abdominal aortic aneurysm that's opened. The aneurysmal part of it is the right side of the picture, and I put the little arrow that shows the distribution, so you can kind of see since it's been opened. And then what I did was I put to the right of it, this is not the same one, this is a different one, but it's an in situ abdominal aortic aneurysm. So you can see the white arrow at the top right, that is between the iliacs and the infrarenal. You see this bulge. And then I put for orientation the right iliac artery, and then below it, what I do is I put for a normal for comparison. So you can see to the right of it, the two iliacs come up, and then the aorta is there, and you can see how narrow it is compared to the aneurysm above it. Here's an individual who had a ruptured abdominal aneurysm. You can see it basically goes from the renal arteries to the iliacs. And then there was thrombus exuded on the surface of it, and there's a size, I can't remember the exact size, it was like 15 or 20 centimeters and that, so large. And then when it's been opened up, this is one that just shows, this is an abdominal aneurysm that's when it opened up. The black arrows to the right of it are the iliac arteries. The blue arrow is actually where the lumen would be, and what that is it's thrombus. And then the wall of the aneurysm, the white arrow has been reflected back. So what happens is when blood's flowing through it, like a saccular aneurysm, the blood will flow through the lumen of where the aorta lumen should be, but it can go off into the aneurysm saccular part and kind of pool and stuff like that. So you often see thrombus or things like that there, and that's what's going on there. So repair, I always have to look up. There's different numbers and everything like that, but I'm definitely not a vascular surgeon. But around 5.5 centimeters, and the 5-6 centimeters the cutoff, because before that they're really much less likely to rupture, like maybe 1% a year. Whereas beyond that, they're much more likely to rupture, like 10, 15% a year. So there's kind of that cutoff. So obviously you want to get the person repaired before they reach that cutoff. So there's different ways to repair. They can put in a graft. The one to the right was actually repaired with a saphenous vein graft. And then also now what's done is they can put in a stent, a little stent in the aorta. And that's what this is. So to the left of it are the iliac arteries for orientation, and the aneurysm is intact. So the black arrow shows where the aneurysm is, and then the next one shows the vessel. The vessel opened up with the graft inside of it. So you can see it's composed of like a little plastic type sheath with this kind of wire mesh in it. Really tough to cut. I have to say, with scissors, it doesn't do very well. But anyway, this one shows you. And then what happens is the aneurysm's still there. They don't fix the aneurysm. They just bypass it, basically. So they basically put in a new narrow lumen that bypasses. So the actual aneurysm stays there, but there should be no blood flowing to it. So these are amazing. I mean, the person can go in and one day walk out of the hospital the next day. And I've seen a fair number of these at autopsy. So this is Flathead Lake, and this is Polson, Montana. You come down a hill into Polson. I just thought this was kind of cool because you can see the lake, and then you see the city, and then you see clouds, and then you see the little peaks of the snow-covered mountains there. That's the Mission Mountains, and then above it you see the clouds. And I remember one of my friends in college was from Polson, and he said when he ever came up the hill at the other end of the valley and saw the missions, he was always very excited. Very, very beautiful mountain range. So we'll talk about berry aneurysms. So berry aneurysms are usually when you hear the word berry aneurysm, you think about the circle of Willis. There could be berry aneurysms in other locations, but the main one I know that when I talk about it would be in the circle of Willis. I'm not even sure if it's used in other places. But the idea is that it's a congenital weakness in the wall, and then as a person has high blood pressure or there's higher uses meth, uses cocaine, things that put strain on, it's going to bulge out. The interesting thing about this, though, is that you can see them in infants. Since I am a forensic pathologist, this does come up every once in a while, and that you can see them in infants, and they can see giant aneurysms. So not only would it likely be a congenital weakness in the wall that bulges out, but it also could just be a vascular malformation where the blood vessel tried to branch and didn't and left this sac, kind of like osteochondroma in the bone. So when they rupture, they lead to a severe headache and a high mortality rate, I think around 50%. And then the main disease association, I've seen this actually at autopsy several times, is the autosomal dominant polycystic kidney disease and berry aneurysms are a very good association to know. And then remember, the pathology is basically a saccular outpouching of the wall of the vessel. So to the top right is the base of the brain. Basically, that's the brain stem there. This is posterior, which is unusual. Most of them are found, or they say most of them are found in the anterior circulation. They're usually the branch points, which might go along with them being an offshoot of it. But actually, in my experience, I found quite a few in the basal and the vertebral region. So one thing about numbers, you always got to wonder. Sometimes it depends, because some of our studies may have been done with an N of 5, and stuff like that. So anyway, the yellow arrow shows the aneurysm and then you can see all the blood around as a subarachnoid hemorrhage. So the bottom the bottom left shows you a really low power view of the saccular aneurysm. It's really hard to appreciate anything there. You just see basically red. Excuse me. But if you look to the right of it, that arrow lines up. So the microscopic close-up on the right corresponds to where the base of the arrow is on the left. And so you can see the wall is to the top left there. It kind of bulges out. And then what's left is fibrin and inflammatory cells. So that's where the rupture site was. So when berry aneurysm rupture, you get subarachnoid hemorrhage, as I've said. That's to the left of it right there, and the high mortality rate. There's some questions about the mechanism. One idea is that maybe because blood's very irritating, and the blood may cause spasm of the vasculature at the base of the brain. Because people with a ruptured berry will die very quickly. I autopsied a person one time who was with friends, basically, with people, and she gasped one time and fell over dead from a ruptured berry aneurysm. So to the right of it, everything's labeled, so you can see there's a Berry aneurysm right there. Oh, sorry. That trifurcation of the left middle cerebral artery should be where the Berry aneurysm is. I just noticed that. Sorry about that. It should be displaced to the right. So where it says white arrow indicates the Berry aneurysm, it was right at the trifurcation. Sorry about that. And then the anterior communicating arteries are right there. So this is one. It was interesting. We would sometimes inject the vertebral and the internal carotid artery with contrast and x-ray it to see if we could see the berry before we open them up. And here's a great example. You can see the berry lit up by it, and then you can see it leaking out. And then to the right of it is the berry aneurysm at the black arrow. So a thoracic aortic aneurysm. So these are in the thoracic aorta. They have a little bit different etiology list than abdominal aortic aneurysms. So they are associated with hypertension and atherosclerosis, but also people with an aortopathy, so Marfan syndrome or Ehlers-Danlos. They are associated with bicuspid aortic valves. They are associated with syphilis, and they are associated with vasculitis. So things like Takayasu's arteritis or giant cell arteritis can potentially be there. So to the right of it is a person with a bicuspid aortic valve. The white arrow shows the bicuspid aortic valve, and the red shows the tear. So there was a thoracic aortic aneurysm there, and then it also tore. Basically, it was nearly circumferential. There's just a little bit of attachment of the intima there, right to the right of the red arrow. So clinical aspects, I talked about this before. Think about it. The eruption of the pericardial sac or the pleural cavity. They can cause dilation of the aortic valve when it leaks down, when it leaks down to it. And like I said, I couldn't really find this in any books or anything like that. Robbins is probably the best one. Basically, it just upsets the annulus and can allow leakage that way. So it can compress the trachea, which can cause a cough. And then if you block the airway somewhat, you can cause dyspnea or pneumonia. Esophagus could cause dysphagia. The recurrent laryngeal nerve could cause hoarseness. So once again, just use your basic anatomy, think about the structures around it, think about the symptoms they might have. Pathology with the syphilis, which is has long been listed as a common cause of the thoracic aortic aneurysms. Important to know, they talk about a tree bark appearance, which I not 100% certain, but the one at the top, I don't think we could absolutely confirm it was syphilis, but definitely looked like a tree barking type appearance. You oftentimes see cystic medial degeneration. You can see that in just hypertension, Marfan syndrome. I've seen people with Marfan syndrome, just pools of blue stuff in their aorta, and that's the bottom right. Like I said, they're associated with the bicuspid aortic valve, and I think some of that might be just the whole area is not right. I think I've heard that basically when they repair the bicuspid, they oftentimes will also repair the aorta, because if they do one without the other, then there's a chance that they'll have problems. And then giant cell arteritis, Takayasu's arteritis, aortitis can cause associated with it too. This is the one that I showed you when I showed the fusiform aneurysm. This is actually this one. So it's just this generalized dilation. And the white area is the one I showed you there that to me, I couldn't 100% confirm syphilis, but that tree barking terminology is what they use for it. The description of the intima of the aorta in somebody with a syphilitic aneurysm, and look like tree bark to me. That's all I got to say. Okay. I just put this in here for Marfan syndrome. People think about Marfan syndrome, they think of, Abraham Lincoln, tall, long fingers, ectopia lentis. You think of the thoracic aortic aneurysms, but there's other things as well too. They're commonly associated with a myxomatous mitral valve, and the top left, they can be associated with a diaphragmatic hernia. And this one, the colon goes all the way up. Push adjacent to the lungs. And then bicuspid aortic valves are associated with thoracic aortic aneurysms. So use reflection, and I forgot, I didn't put the question in here. I'll just add to the third one, sorry about that. But go back and think of what are 5 things you learned from this lecture, hopefully if you learned 5. And like I said, this is a good way to cement the material. And then this is just a field up along Highway 56. I just like that part of my home state, and I hope the lecture was useful to you, and thank you.